joining us. We have people from all over the country joining us, so I want to welcome you, and please put in chat if you'd like where you're watching this from so that we can see the geographical diversity. I'm Kara Cohen with AARP Massachusetts. So AARP maintains a deep focus on the health and financial security and personal fulfillment of people 50 and over and their families. And I think you'll find that reflected in our programming and in our resources and in our advocacy. And AARP is leading the fight for the issues that matter most to you. We're working to strengthen Medicare, safeguard Social Security benefits, and champion the rights of older Americans. And AARP is urging Congress to better support family caregivers, make communities age-friendly, and crack down on fraud. And thanks to our millions of members, we are winning the fight. In a historic victory, AARP led the charge for new Medicare prescription drug reform. And starting January 1st, a new $2,000 cap on prescription drug costs will take effect, saving Medicare enrollees who reach the cap an average of $1,100 a year. And additionally, for the first time, Medicare will have the authority to negotiate lower prices on select high-cost medications. This is an enormous step forward for affordable health care, and this is all great news for older Americans. We are so pleased to collaborate with the Alzheimer's Association on this offering and another one later this month. That is all part of our November webinar series for caregivers. You can find the rest of the AARP caregiver webinar series at this URL that will be entered into chat as well. It's aarp.org/caregivingma. We have a session coming up on the 6 pillars of brain health and another session on universal design features for our homes as we age. Also, you can keep up with all else AARP has going on near you. That can be found at aarp.org/local. And to check out AARP's vast reservoir of resources for family caregivers, please go to aarp.org/caregiving. And finally, you'll find more to check out at the AARP Brain Health Resource Center at aarp.org/brainhealth. We offer lots of tips there and tools and explainers on brain health. All right, that's it from me. Enjoy the program.
Well, thank you, Kara, and welcome everybody to our program this evening in honor of November being National Family Caregivers Month. And we are delighted that we are co-sponsoring this event with AARP Massachusetts. So my name is Lorraine Kermond. I am Manager of Professional Healthcare Education at our Massachusetts, New Hampshire chapter. And we are excited to have people all across the country. I can see the locations coming in to let you know that tonight's audience is comprised of both families and professionals in the field of dementia care. We are grateful that you've chosen to spend the next hour with us, and we're confident that you will find it informative and helpful. So for those of you joining us for the first time, I just want to share a little bit about the Alzheimer's Association. We have a dual mission of accelerating global research and its dedicated services, helping individuals, families, and our communities navigate the complexities of Alzheimer's and related dementias. One of our best resources is our helpline. It's available to both families and professionals. It's available 24 hours a day, 7 days a week, 24/7 helpline at 1-800-272-3900. So whenever you call us, day or night, you will be talking to a specialist at the Alzheimer's Association, and we provide confidential information and support about local resources and strategies to help you through this journey and experience. We also provide support groups and a wide range of education programs, both in person and our local communities and virtual. So you can take advantage of our services in whatever way that works for you. And all of our services for people living with dementia, caregivers, families, and the public come at no cost. And new this year, we're excited to offer free CEU programs on a wide range of topics for professionals in the dementia care field. So before we get started, I'd like to just mention a few housekeeping items. Due to our large audience tonight, we have muted your microphones and cameras, but we do want to hear from you. So please feel free to put your questions in the Q&A in the bottom of your screen, and we will get to as many questions as we can at the end of tonight's program. And be sure to keep an eye on the chat where we'll put some useful links and additional information about resources and topics mentioned tonight. We will also be recording tonight's presentation, and it will be sent to all registrants, and it will be posted on our website in a few days, so you will receive an email from us. And for professionals in our audience tonight, this program is approved for nursing and social work CEUs. Professionals outside of that disciplines can receive a certificate of attendance. To be eligible, you must attend the entire program and complete the post-test evaluation, which will be sent to you tomorrow via email. So it is my great pleasure to introduce tonight's speakers, Dr. Brent Forester and Mr. Tom Harrison, co-authors of the book, The Complete Family Guide to Dementia, Everything You Need to Know to Help Your Parent and Yourself. So Dr. Brent Forester is the Dr. Francis S. Arkin Professor and Chair of Psychiatry at Tufts University School of Medicine, Psychiatrist in Chief and Chairman for the Department of Psychiatry at Tufts Medical Center, and Director of Behavioral Health for Tufts Medicine. Dr. Forester is also currently serves as the interim chair for the Department of Neurology at Tufts Medical Center. He has spent a quarter of the century of his professional career at McLean Hospital and Mass General Brigham, where he served as the chief of the Division of Geriatric Psychiatry at McLean Hospital and the senior medical director for value-based care solutions in the Population Health Management Department at the Mass General Brigham. He is an expert in geriatric psychiatry, specializing in the treatment of older adults with depression, bipolar, and behavioral complications of Alzheimer's and related dementias. He is the past president of the American Association for Geriatric Psychiatry, a distinguished fellow of the American Psychiatric Association, and has previously served on the board of directors of the Alzheimer's Association, Massachusetts, New Hampshire chapter, and chair of our Medical Scientific Committee. Dr. Forester's research on novel treatment approaches to manage the disabling behavioral complications of dementia, such as agitation and aggression. Dr. Forester's work also includes the implementation and evaluation of collaborative care models for comprehensive dementia care within the primary care settings. So he will be joined tonight by Mr. Thomas Harrison. Mr. Harrison is a journalist and co-author of The Complete Family Guide to Dementia, published by Guilford Press, as well as a dementia caregiver himself. He is the co-author of The Complete Family Guide to Addiction, which was also published by Guilford Press. And he was the editor and publisher of one of the country's best-selling legal journals. So again, thank you all for joining us this evening. And it is my great pleasure to hand it over to Dr. Forester and Mr. Tom Harrison. And thank you very much.
Well, thank you, Lorraine. Thank you, Kara and Nicole and everybody who's put this program together. And thank all of you for being here tonight. I'm Tom. I'm a professional writer, and I had two grandparents with dementia, and my mom had dementia. And I was her sole caregiver for years. And as a writer, I always thought, there must be some book out there that I can find that would tell me about, this extremely difficult, challenging experience that I'm going through. And I never found that book. I found memoirs. I found what I call patient care manuals. These are books that written by doctors that say, here are the 248 things to keep in mind when you're giving your loved one a bath and so on. But I never found a book that was for me as a family caregiver. And so I finally decided I should write that book. And I was tremendously privileged to be able to work with Brent Forester, who is a rock star in the field. He's a brilliant researcher, a brilliant clinician, a caregiver himself, and a marvelous human being. And so we produced together the complete family guide to dementia. And tonight we have a lot of family caregivers. We also have a lot of caregiving professionals. And I thought what I would talk about is this. Dementia is a unique disease. It has unique problems. And one of those problems is that the nature of the disease often causes friction between families and professional caregivers. They sometimes talk past each other. They step on each other's toes. They don't always see eye to eye. And a lot of that stems from the nature of the disease. So I wanted to talk about why that is and what we can do to make these relationships work better. And the first thing I think to recognize is dementia is the hardest disease that there is of all diseases for families to care for. And it's not even close. It's incredibly difficult. As the disease progresses, it's 24/7 care. And people who do it find they give up time with their families, they give up their social life, they give up their hobbies. They stop eating well, they don't sleep enough, they don't exercise. And nearly 1 out of 5 family dementia caregivers will develop serious health problems themselves as a result of providing care. So it's incredibly intense care. It's also very lengthy, right? Almost everyone who does this will do it for at least a year. A third of people will do it for 5 years or more. And that combination of intense care and lengthy care makes dementia unique and extremely difficult to care for. But that's not all. With almost any other illness you're taking care of someone for, you can at least anticipate they'll cooperate with you. They'll help. No, with dementia, the person isn't able to cooperate even if they wanted to. And in many times, they're actually obstructing you. They're because they're paranoid or they're agitated or they're defiant. And that's incredibly difficult. With most other diseases, they're at least predictable. It may be really hard to take care of someone, but at least you know 11 o'clock on Tuesday morning what you're going to be doing. With dementia, there is no predictability. You don't know from one day to the next what you're up against or 1 hour to the next. And that is extremely stressful. And people report their stress level is extremely high. It's a disease that isn't well understood by the general public. They don't know what's involved in it and what's involved in taking care of it. And for that reason, caregivers often don't get the kind of social support from friends and even family that they would get if they were taking care of a different disease. And don't discount this. Dementia is embarrassing. You know, every time you take your loved one into public, there's a chance they're going to say or do something humiliating or offensive. Everybody who does this has a story, right? My mom developed the habit of walking around in public stark naked. That just doesn't happen with other diseases. And people who care for dementia feel guilt, right? No one feels guilty when they put their dad in the hospital because he has cancer, but people feel guilty all the time when they put their loved one in a dementia care facility, even if it's necessary. They feel guilty when they take away the car keys. They feel guilty when they feel like they're treating their parent as a child. They feel guilty when they feel like they have to lie to their loved one to get them to do something they need to do. So put that all together. It's intense, it's lengthy. You don't get cooperation or predictability or social support. You do get embarrassment, you do get guilt. And what happens to these families over time is that they become stressed out to the max. They become burnt out. They're at the end of their rope. They are emotionally and psychologically broken. And that is the point at which the professional comes into the relationship, right? And that's incredibly difficult right there. I mean, if someone's in the hospital for a heart attack, well, the family's in shock, but they haven't spent years being ground down into emotional brokenness. So that in itself causes problems, when dealing with families and professionals. But there's a lot else. There are a lot of other things that cause problems. Unlike most diseases, dementia is denial friendly, right? A lot of people who have dementia are in denial. If somebody's in the hospital with a heart attack, you can't deny it. But because the symptoms of dementia can mirror symptoms of normal aging, a lot of people can misattribute it and say, oh, it's just normal aging. Because the decline is so gradual, people who are there every day, especially spouses, do not perceive over time how bad things have gotten. You know, they may tell themselves it's not so bad because they're losing a loved one, and that's hard. And an objective observer, like a professional, may see things very differently. And then you have people talking past each other and not seeing eye to eye. And that creates friction. If your loved one's in the hospital with kidney failure, no one assumes they know better than the doctor how to deal with that, right? Everybody says, I don't know what to do. You know, go to the doctor. But with dementia, often before the professional gets involved, the family's been doing it all for years. They feel like they know how to do it. They understand, and they feel like they understand it better than the professional does. You know, it's one of the rare situations where the family of the loved one feels like they understand the care better than the professional. And so coming at it from different angles like that also creates friction between families and professionals. Yet another problem is what I'll call professionalism. When you have a serious illness and you go to the doctor, you want that doctor to have an attitude and a demeanor of professionalism. And if you think about what that means, it means a certain amount of detachment, objectivity, a little bit of distance, because that reassures you that they're educated, they're trained, they know what they're doing. You want that. But here's the thing. You want that because you know it's a serious disease. But a lot of families of people with dementia have not been taught to understand that this is a real disease. Historically, there's been very little doctors can do about dementia. So medical schools don't teach a lot about dementia. So doctors, when they diagnose it, don't know a lot of what to tell families. They sort of say, well, it'll gradually get worse over time, but they don't really emphasize how difficult this will be and how serious it is. And it is a serious disease. It's a debilitating, progressive, ultimately fatal brain disorder. It's every bit as serious as diabetes or kidney failure or heart disease. But families often perceive it as just getting older faster, right? They don't see it as a real disease. And because of that, when professionals get involved, they don't see them as real professionals. And so they sometimes misinterpret the professional's professionalism, that demeanor, that detachment that you want normally. They don't see it that way. They perceive it as lack of caring, as being aloof, as a failure of compassion. And that creates friction between families and professionals. Here's another thing. If you're caring for someone 24/7 for years, that becomes who you are. That's yourself. That's what you do. That is your identity. And you may be at the end of your rope. You may be falling apart. You may be desperate for help. But when someone takes some of that burden from you, there's a sense in which you're going to feel like you've lost your identity. Like somebody's taken away something that's a part of you. You know, it's something people experience when they retire or they lose their jobs. Like, who am I? I've lost my meaning. And so many people, many family members will try to hold on to a little bit of that and keep it so that they keep a sense of their identity. And professionals sometimes misinterpret that as meddling or complaining or nitpicking or micromanaging. And it's not really those things. It's really kind of holding on to a sense of identity because it's been suddenly taken away from you. And that creates friction. And here's one more. No, when you put your loved one in the hospital for any other disease, cancer, whatever, you don't feel like you're a failure because you didn't have it, right? It's the appropriate thing to do. But because families don't see dementia as a real disease, when they have to bring in professionals, they often feel like that's a failure. They failed. And they didn't. It's absolutely not true. It's not a failure. It's just that's the nature of the disease. It's eventually reaches the point where you can't do it all yourself, generally. But people feel like it's a failure. And if a professional comes in and does a great job where they didn't, they can feel like more of a failure, right? And so sometimes unconsciously, they kind of want to throw a little wrench in there to make it a little more difficult so that they won't feel like they failed quite as much. Not always, but it sometimes happens too. So all of those problems are not obviously present in every case, but they're all things that can happen. And they all add up to creating a stress, a little miscommunication, tension between families and professional caregivers. And it's unique to dementia because it stems from the nature of dementia. So I want to suggest 3 things that may help this relationship. And they're ways of reconceptualizing things. And one is, I think we should start thinking of dementia as a family disease. It's not just the person with dementia who's sick. It's the whole family that is sick. It's the whole family that is debilitated. It's the whole family that's suffering. So for families, I think what this means is understanding your own limitations, understanding that you're suffering too, right? And you don't have to take the whole burden on yourself of everything when that burden is overwhelming, and something that you would not be expected of anyone with any other disease. But for professionals, I think it's important to look at not just serving the person with the dementia, but serving the whole family, because families are circuits. Families are an ecosystem. So you don't want to think of it as I'm serving the person with dementia and the family is over here or the family's in the way. You want to look at serving the whole family, because often the best way to help the person with dementia is to help the family. If the family can have some sort of recovery and they can get their feet on the ground and they can take care of themselves, they're often much better at providing care for the person with dementia. So I think it's important to think of it as a family disease. Here's the second thing, and this is for professionals. Anytime you deal with someone with dementia, what you eventually learn is that they have a lot of trouble with words, right? They're not good at communicating through words. And one thing that everybody learns eventually is you can hear the words, but listen for the feelings, right? Because the words might not make sense. You might not be able to understand what the words are saying. But if you can hear what the feelings are and you can respond to those feelings, you can still have a very successful interaction and the person will feel understood. And I think it's good if you can take that same attitude to the family members, because remember, it's a family disease. And because if you hear the words might be a stressed sense of complaining or micromanaging or nitpicking or disagreement or whatever. But if you hear the feelings, what you're going to hear is fear, loss, a sense of powerlessness, a sense of hopelessness, a sense of guilt, a sense of shame, and grief. And if you can respond to those feelings instead of just the words, you're going to have a much more successful interaction and everyone's going to feel understood. And then the last thing is this. With a normal disease, any other disease, cancer, someone's in the hospital, everybody instinctively, automatically understands the different roles, right? The doctor's there to manage the treatment. The nurses are there to provide direct care. The family's there to support the patient. We all get it. It's natural. But because the treatment trajectory of dementia is so different. Those roles get muddled and there's a lot of confusion. And I think it's really important for families to understand the roles and professionals to teach those roles to the family so they understand. Because the main thing families have to understand is that the professional is not there to usurp you. The professional's not there to take your place. The professional's not there to replace you, or to take anything away from you. The professional is there so that you can offload onto someone else everything that someone else can do, so you can focus on the really important things that only you can do, right? And the professionals will not do it exactly the way you would, but that's okay. They don't have to. It'll get done. The important thing is to be able to focus on what only you can do, which is to love the family member, right? It's to hug them. It's to hold them. It's to laugh with them. It's to share stories. It's to listen to music that they like. It's to reminisce, to share long-term memories, which they may still have. And it's to make them feel loved. Because that is the most important thing. That is the thing, the number one thing that will give them the best quality of life. And if you can focus on that, that's the most important thing you can do. And that is the thing that will give you the memories that you will take with you when that person is no longer there. So those are my suggestions. And I will turn it over to Brent, and he will give you his clinical perspective. Thank you very much.
Thank you, Tom. For those of you in the audience who have not heard Tom speak before, when I first met Tom and he came to me with his manuscript that he was preparing, that is now our book, it was remarkable to me, for Tom, who's a journalist and not a clinician, the clinical insights that you have, Tom. And that last part in particular about the feelings is so true. And it's easy for us to understand that intellectually. And it's very hard in the moment to act on it in a way that can be productive. So what I wanted to talk about are three things. And I've already seen lots of great questions in the Q&A in the chat, so we'll have plenty of time to address those. The three things that I wanted to talk about is diagnosis, and why diagnosis is often delayed, and why it's so hard to even get a diagnosis. The second is what's not working well in healthcare systems to allow for effective diagnosis and treatment, and what we might be able to do better, and some examples of how that's happening now. And the third is around an aspect of this illness that Tom alluded to, and all of you have loved ones with dementia. I've already seen questions in the chat about, which are the behavioral and the psychological symptoms of dementia, and how I think a clinician approaches those symptoms that might be helpful for both professional caregivers and family members. So the first, in the United States today, you've seen these facts and figures before, most likely, but we have approximately 7 million Americans with some form of dementia, with the Alzheimer's type being the most common. And we know that because the population is aging rapidly, with the baby boomer generation aging into the 65 and above category, we're likely going to see a near doubling of this number, absent an effective treatment over the next 25 years. Unfortunately, only about half of those people with dementia are ever diagnosed. And the half that are generally do not come to the attention of a medical care provider of any kind to establish a diagnosis until they're well into the illness, in the moderate stages of illness, when they can no longer drive or pay their bills or meaningfully work. And so we're losing out on an opportunity for a number of things. One is effective planning, engaging families and individuals with this disease in a discussion about how to care for that person over the course of this journey, which can, as Tom said, take years and years. So the delay in diagnosis happens for a whole variety of reasons. One of the reasons is related to the confusing nature of the presenting symptoms. We see cognitive problems, memory loss with normal aging. And telling the difference between normal memory associated memory loss with aging is difficult to tell that from a clinical condition we call dementia. It's also true that there are many medical factors that can be associated with memory loss that are not Alzheimer's disease or other forms of dementias. Depression, for example, or anxiety, or medication side effects, or somebody with alcohol or other substance use problems. All of those can masquerade as a memory problem and don't necessarily indicate an underlying dementia. So sorting out the cause is really critical, which is why bringing someone to the attention of a clinical provider, often a primary care physician to start with, is so important. The other factors that confound and delay the diagnosis have to do with some of the feelings that Tom was alluding to that are really part and parcel of this disease, which is that a lot of people with the illness themselves or their loved ones are frankly frightened by the possibility that this may be the diagnosis. And so fear may be part of the reason for delay. The other may be just minimization and denial, like, mom or dad or my spouse or my sibling are getting older, and that's just normal. So there's minimization and denial, which is a protective mechanism against that fear. And then there may be other factors related to the fact that our healthcare systems, our primary care practices, et cetera, are not really organized and equipped and structured to adequately assess and manage dementia. We, to this day, do not have a single easy to assess blood test, let's say, or one brain scan, or one easy cognitive test that will say, yep, that's Alzheimer's disease. It's really a comprehensive assessment. And we don't have enough specialists in the field of dementia care, whether they're, like I am, a geriatric psychiatrist or a neurologist who specializes in dementia, or a geriatrician. There aren't enough specialists in the world to diagnose and treat the volume and numbers that we talked about before. So we have to rethink the way we assess individuals with memory complaints in a systematic fashion. And that's currently non-existent in healthcare. So there are many factors that go into this delay in diagnosis, but getting that diagnosis is critical so that we can focus instead on what somebody with dementia can't do. We can focus rather on what they still can do and sometimes can do quite well to maximize those strengths, to engage people in meaningful activities socially, sometimes professionally, and to improve quality of life. As Tom said, this is truly a family disease, not just for the person with the illness, but for the family as well. In 2024, the Center for Medicare and Medicaid Services, otherwise known as CMS, launched a new payment model through their innovative payment organization called CMMI. And this is a model we call GUIDE. It stands for Guiding an Improved Dementia Experience. And GUIDE is a payment model for a care pathway, if you will, and a care team to support people with dementia and their families where they're receiving clinical care. In the primary care office, in a specialty memory clinic, it could be applied anywhere. And 400 healthcare systems in the United States or practices applied for this model, or more than that applied, but 400 received the opportunity to participate in this 8-year program. This 8-year program will require that these healthcare systems collect systematic data on clinical symptoms, on diagnosis, on supporting families, on supporting individuals with the illness, on connecting them to resources in the community, on doing all the things that we know from years and years of evidence improve outcomes in terms of clinical symptoms for people with the illness, caregiver outcomes, as well as reducing the overall burdensome costs of care. And until GUIDE came out, which was just in July of this year, there really was no payment mechanism for what we know is gold standard dementia care that will help support families through the journey. So I combined the topic of delay in diagnosis and healthcare system issues with a potential solution that is now here and is something that you all should look into to see whether or not your primary care clinician is involved. And the Alzheimer's Association remains to this day one of the best single resources for families looking for help and guidance through a number of the programs that they run, but can all be accessed through their 24/7 helpline. The other thing I'll just say about healthcare systems is when I talk to my colleagues in primary care, they really want to help their patients with memory problems, and they know it's an issue, but they don't feel that they have the tools, the knowledge, or the time to do an adequate assessment of the person, to communicate the diagnosis, and to provide them with the resources that they need, which is why these care models are so critical for us to figure out if we can truly implement them in a large way. If you think about dementia care in 2024, it's not unlike what cancer care looked like in the 70s or even into the 80s. We're talking 40, 50 years ago. And I say that for a couple of reasons. One is stigma. Cancer, when I was in medical school in the 1980s, highly stigmatized illness. Sometimes physicians did not even want to communicate the diagnosis to a patient. They would just whisper it to a family member. They had very few tools. We didn't understand the genetics of cancer very well. We didn't have the targeted therapies we have today. And what's built into cancer care in 2024 is psychosocial care, psychiatric care, mental health care for individuals and their families in gold standard cancer centers. We don't have that yet for dementia care, but we need to move in that direction. We also don't have what cancer care has, which is diagnosis early enough using biomarkers and the like, but we're moving into that reality soon. So if you think about it, we're well equipped in cancer care to not only diagnose people early, treat patients well, but we improve the quality of life with people with cancer and that of their families. And that's the direction that I think the dementia field needs to go in. The last thing I want to talk about is what I think and what we know from the literature is the most disabling aspect of Alzheimer's disease and other dementias. It's really not the memory loss or the repetitive questions. It really truly is the behavioral consequences of this illness because of the changes occurring in the brain. And those symptoms can include anxiety and worry. They can include verbal or physical agitation or even aggression. They can include paranoia or hearing or seeing things that aren't there. All of these are symptoms. They're not diseases, they're symptoms. And they're caused by a whole myriad of factors. And our job in the clinical world, and your job as both professional and family caregivers, is to understand why. Like, why is Mrs. Jones acting in this way that she wasn't acting in a week ago? Or maybe it's been going on for 6 months. And so there are a few things I just want to point out that are really critical in establishing the why. The first thing is to get a really good understanding of the story and the time course. Did this start yesterday or has this been going on for 6 months? How severe is it? How frequent is it? When does it occur? What prompts this behavior in their environment at home or their interaction with a loved one or the time of day? We need to know the precipitants, and I would call these the environmental precipitants of these behavioral changes. So that's one bucket of causes. The second is medical. We know that people who have changes in their brain related to dementia, amyloid plaques, tangles, degeneration of the brain, people with dementia are very sensitive to any change in their health. This could be an infection due to a urine infection, or maybe due to COVID, or maybe due to a medication side effect, or maybe due to constipation or pain, or maybe due to an alcohol use disorder, or a side effect of an over-the-counter medicine that the person thinks is harmless, that they're taking for sleep, like Tylenol PM, but it's actually making memory worse and sometimes making mood or agitation worse. So all of these medical factors must be taken into consideration as driving the why of these behavioral problems. And the third bucket of causes are psychiatric problems. So people who have had a long-standing history of depression or bipolar disorder or an anxiety disorder are not immune to having recurrent symptoms as they get older. And especially if their brain is now changing because of the ravages of dementia, they still can have recurrent depression. And so the way we approach it and treat it may be a little different than in someone who never had these psychiatric symptoms until they had dementia. Now, all that I told you there, as Tom mentioned, what I would talk about are clinical issues. These are clinically really important details that a clinician needs to assess, and that you as a family member or professional caregiver can point out to clinicians who are caring for the individual so that that clinician knows that this is just not normal for this person, that this represents a change so that we can figure out the underlying cause. One of the reasons I mention the behavioral symptoms is because I worry that these symptoms, despite their prevalence and the impact they have on the course of illness and the quality of life for the person with the illness and their care partner, despite all of that, we don't have many evidence-based treatments that are approved by the FDA in terms of medications. In fact, we have one, but we use a lot of different treatments. And not all clinicians who care for people with dementia appreciate the nature, the severity, the frequency, and the impact on the caregiver that these symptoms can have. So a holistic approach to dementia care is not just an assessment of memory and thinking and judgment. It's not just an assessment of day-to-day functioning, but it's also an assessment of these behavioral symptoms. So being alert to these can often lead to a dramatic improvement in one's quality of life. The last thing I'll say about this before we go to questions, so we'll have a lot of time, is that when you have a loved one that you're caring for, or you're a professional caregiver, and there's a rapid change in someone's thinking and memory, or a rapid change in their behavior, and by rapid, I mean over the course of a day or two or a week, that is almost never a rapid progression of dementia. We get this question all the time. Seems like, Mrs. Jones's dementia is all of a sudden getting worse. Dementia does not all of a sudden get worse. Rarely does that happen. Instead, what's happening is something else is going on medically. Again, like I said before, it could be a medication side effect of a new medicine prescribed, an infection. The list is very long, but it begs a careful evaluation because so many people go untreated with very, very treatable problems over the course of this illness. So what I want to leave you with is maybe a pathway forward. And we talk a little bit about this in the book, which is it is very difficult for families to bring to the attention of a professional clinician that their loved one is having dementia. Too often, older people see their primary care clinicians on their own without a family member nearby. And I spend a lot of my time educating my colleagues in primary care how important it is to involve family in the care of older adults, especially anyone with cognitive complaints, because the true diagnosis comes about through a careful history. So a future in which we can, as we talk about in the book, be proactive instead of reactive, and that we react often to crises as opposed to being proactive about understanding what's going on. The more we can be proactive, the more really, I think you as a caregiver can feel some control over what is often a very out of control situation. And I really highly encourage people to be proactive around recognizing and treating, not to give someone a diagnosis that makes you feel awful, but rather to give them some hope about understanding what's going on and what we actually may be able to do to improve quality of life. So I'm going to stop there. And I'm going to turn it over to my colleague, Lorraine, who's going to lead us through the Q&A. So thank you.
Wonderful. Well, thank you, Mr. Harrison, and thank you, Dr. Forester. That was incredibly informative. Lots of important information about how to encourage families and professionals to partner to provide the best care, and importance of early diagnosis and treatments and care approaches. So thank you. Thank you. We have lots of questions tonight. So I'm going to start with Dean, who's wondering if you have any tips. He will be moving a friend into memory care in the next few weeks, and he's really looking for how to help with that transition.
Tom, you want to start with that one?
Sure. As it happens, there's a whole chapter in our book, The Complete Family Guide to Dementia, that talks about how to transition someone into a memory care environment. And there are lots of, there are lots and lots of little practical tips as to like what you bring with the person, whether you take them there first or not, what you tell them about what's going to happen, how long you stay, how often you visit them afterward, and that sort of thing. But I think for our purposes, the single piece of advice I would give to anyone in this situation is talk to the memory care facility, talk to the people who work there, because they've done intake on an awful lot of people and they've seen in their environment what works and what doesn't work, and ask them really practical questions. What time of day do you bring this? What do we bring with us? What don't you bring with you? And what do you tell them? How long do you stay? What do you tell them when you leave? It's off, a lot of people who come to these facilities will say, they'll tell everyone there, I'm just here for a day or two, right? And you don't necessarily have to contradict that. You can kind of let them believe that, because that's their reality, and that's how they're acclimating themselves to what's going on. But I would say that the best thing is, while we offer many suggestions, the simplest thing is talk to the facility and see what they have found in their experience in their facility works best, and ask lots and lots of little practical questions.
In addition to everything Tom said, which is completely accurate and also in our book, I would offer one other insight that I've seen over the years, which is that most families feel tremendous guilt and shame about even making this decision. And sometimes they feel that they're breaking a long-held promise to their loved one that they would never do this. And I'm sure many of you can identify with that. And having treated so many people over the years with this condition and worked with lots of families, I've heard a consistent theme. And the theme is this, that once the decision is made and the loved one moves in and acclimates to a new situation, 99.9% of the time, the families come back to me and say, I can't believe we waited so long. And they were waiting so long because they were waiting for the person with the illness to say it's time. And that's never going to happen. And the decision is really a difficult one. And it's a difficult one that the caregivers and the rest of the family have to grapple with. There are a lot of people who can help with that decision, of course. And a lot of the tips that Tom just mentioned can be helpful, practically speaking. But at the end of the day, it's about the feelings of guilt around this decision that sometimes makes this really hard on all of you as caregivers.
And I would like to add just two more little things. One is, the longer you wait and the more the person declines, the harder it is to make that transition and the more difficult it is. So doing it sooner gives your loved one a better chance to do it successfully and to acclimate. And the second thing is, everyone who makes this transition will experience a sudden decline. It's difficult, it's challenging, it's hard, and everyone who does this, almost to a one, will have a negative reaction. It'll seem like they're unhappy, they're miserable, they're upset, they're declining. That is just a normal function of a transition. And many people quickly say, "Oh, this didn't work," and they have second thoughts. But that reverses itself. That's a temporary thing, and you should expect it and be prepared for it. It does not mean you made a mistake. It's just, it would happen anyway, and it's totally normal, and it will right itself.
Great, thank you very much. And Tom, something you said earlier was that as the caregiver, your role doesn't end, but it just changes, that it allows the family now to have that opportunity to really come in and provide that love and support in a different way and not be as exhausted with the day-to-day care. So I think that's a really incredible and important point as well. So wonderful. So someone else was talking, Julie was mentioning her husband was diagnosed with MCI, and it's been a slow progression, but she's just wondering what are the next steps if you're concerned about the progression of getting a diagnosis?
I can start with that one. So in terms of getting a diagnosis, I talked about this a little bit. This could and should be done by a primary care physician, but oftentimes they don't have the tools, the time, or the knowledge to do it. And so you wind up needing a specialty evaluation. And there are, thankfully, at least in the New England area, many wonderful memory centers, if you will, of excellence, where a comprehensive assessment can occur. Now, part of that comprehensive assessment is a diagnosis, let's say of mild cognitive impairment, which is the first stage, if you will, in the journey of dementia progression. It's when people have a cognitive decline, but their day-to-day functioning remains pretty normal. And part of the team should include a physician who's a dementia expert, as I mentioned. Sometimes a neuropsychologist will do a very detailed assessment of thinking, memory, and other aspects of cognition. And hopefully the team also has a social worker or a care navigator who can help families with a lot of the practical aspects of this illness that, again, we talk a lot about in our book. But one of the questions that I often will respond, like one aspect of your question that I do want to mention, because I get this a lot, is like, what should I expect in terms of course of illness and prognosis? And I think what's really important to remember is that there is no one pathway that everyone follows, that this is a highly individualized disease. Not all dementia is the Alzheimer's type. There are other types caused by strokes or by other types of dementias. But the three things that predict the prognosis and the course are important to be aware of, because they're actually things that families and even individuals with the illness can have an impact on. One is overall health. And so if someone has MCI, you want to also still pay attention to their blood sugar and their cholesterol and their heart disease and their risk for other illnesses and their infection risk and all of that. Because the more that you can do to maximize overall health, the more likely the course of illness will be more gradual. And again, the goal here with this illness that has no cure is to maximize quality of life and functioning as long as possible. The second is behavioral health. So paying attention to mood, anxiety, agitation, and so forth, those symptoms not only are distressing to the person with the illness and the caregiver, but they drive the course of the illness. Oftentimes it will predict the pace of progression, and it will certainly predict the impact on the caregiver. And then the third prognostic factor is everything that's around the person with the illness, the environment, the ability of the person to still engage in meaningful activities, social engagement, as I mentioned before. Some people do keep their brains healthy with aging in all sorts of ways, from cognitive stimulation techniques and so forth. But those three factors will determine the outcome of this illness: medical factors, behavioral health factors, and the environment. And those are all things that are modifiable. And again, my message for all of you is that we want to look for those factors that will maximize quality of life and functioning, and try to reduce decline as much as possible.
I want to make one comment about diagnosis. Diagnosis is great. It's wonderful. It can be extremely helpful. In the real world, many people who are exhibiting signs of memory loss do not want a diagnosis. They don't want to go in for one because of denial or because of fear. And it's not infrequently the case that one family member wants to get a diagnosis, but other family members do not want a diagnosis because of their own denial or their own fear. And what do you do in that case? And I think it's great to have a diagnosis, but sometimes the way diagnoses work often is that you look for the signs, that the symptoms that are consistent with dementia, and then you try to rule out anything else that might be producing those symptoms. So what you can do, if you don't want if your loved one or does not want to go in for a diagnosis, you can talk to the doctor and then bring your loved one in for a checkup, and the doctor can then see if it's possible to rule out any other cause, which is very important, because if there is another cause, you might be able to solve it. Right? And if there isn't, well, then you may not have a formal diagnosis, but you kind of know, and that will help you to move forward. So just a thought.
All right, great, thank you. And I'm just going to move on to a question about treatment. So a question came in regards to the effectiveness of the current treatments to slow the progression of Alzheimer's, and treatments that have been recently approved by the FDA. And how do they compare in effectiveness?
Okay, we only have a few minutes, but I'll try to be quick. So there are 4 drugs on the market since the beginning of the early 90s that slow the progression of the disease while people are on the drug. Those are called symptomatic therapies. They essentially address the chemical changes that occur way, way downstream in the illness. Three of the drugs increase a chemical called acetylcholine, the most common of which that you've probably heard of is called Aricept or donepezil. It basically increases this chemical in the brain, which we need for normal attention and memory. When you remove the drug, the benefit you had goes away, and sometimes it goes away fast. And so there can be a somewhat precipitous decline after prematurely stopping it. But in 2024, the gold standard treatment of these symptomatic therapies are combining one of the cholinergic drugs like donepezil or Aricept with another drug that works on the glutamate system in the brain and reduces glutamate toxicity, if you will. That's called memantine or Namenda. That combination remains the gold standard. And the decline, generally, the difference in drug and placebo in the trials was after 6 months. So we know that there's a difference after 6 months that's statistically significant, often clinically meaningful. But we really don't know how to predict who's really going to benefit and who won't. The good news is mostly these drugs are relatively safe. They're all generic, so they're not as expensive as they were before. And there aren't tremendous number of drug interactions, but that definitely remains symptomatic therapy as a gold standard of care. The other part of the question is the new treatments. And so beginning about a dozen years ago, I have been personally involved, as have all of my colleagues in the dementia expert area, with clinical studies that have looked at anti-amyloid and anti-tau antibody therapies. These are medications that are given intravenously once a month or twice a month, and two of them are now on the market, lecanemab and donanemab. These drugs are modestly effective. What does that mean? If you infuse the drug over the course of 18 months, there's a statistical and clinical difference at the end of that 18 months in cognitive symptoms and in functional symptoms, and overall about a 26 to 30% slowing of decline, which might not seem like a lot, but that could add up over time to quite a bit. Actually, again, remember, our goal is not cure because we don't have that. It's maximizing time with higher quality of life and higher functioning. Those medications are now being delivered in centers around the country and in a few other countries around the world. It's been very challenging to get these treatments stood up in clinical practice because of all of the risk factors for bad outcomes with these drugs. So the side effects that we worry about, which thankfully are relatively uncommon in terms of their symptoms, the side effects that you would notice, are brain swelling and brain bleeding. And anytime you're talking about bleeding or swelling in the brain, it's not good. Now, luckily, like I said, we know who's at risk for this. It's based on genetics, and it's based on if you're on blood thinners and a few other factors. And so we can really target the treatments to people very unlikely to have bad side effects, which cuts down on the number of people who could benefit from the drug, frankly. The last thing I'll say is new therapies. Thanks to the bipartisan congressional support of funding and a lot of advocacy from the Alzheimer's Association and other groups, there's been remarkable increase in funding at the federal level through the National Institute of Aging for Alzheimer's disease research, whether it's diagnosis and biomarkers or treatment, like I talked about, and a huge investment by pharma and biotech. And these forces together have really led to our understanding of other pathways of disease. And so I would predict in the next few years, you're not going to just see more medicines like what we now have on the market, but other pathways that have to do with inflammation, for example, in the brain, et cetera, will be really important to try to alter the course of this disease.
Okay, well, thank you. I know that was a big loaded question, and it was, thank you for your concise and informative answer. So unfortunately, we've come to the conclusion of our program. And I apologize if we were not able to get to your question, but please remember you can call our helpline at any point in time and we can give you information, and call us at 1-800-272-3900. So I want to thank everyone for joining us tonight. I want to give a special thanks to AARP Massachusetts for being our co-sponsor. And I especially want to thank our presenters tonight, Dr. Forester and Mr. Harrison. We hope that you found tonight informative and helpful. Just a reminder, this program has been recorded, so you can share that with family and friends. You will receive an email in the upcoming days with more information about how to access the recording. And again, if you are looking for a CEU certificate for tonight's event, you will receive an email tomorrow with a post-test evaluation. So thank you, everybody, and we hope that you will join us at another program soon. Good night.